Okay, well, we might as well get started now. It's 1 o'clock. For those of you who don't know me, my name is Alan Clark. I'm the Regional Knowledge Coordinator for Mental Health and Substance Use. And today we're presenting on some of the top relevant issues and the changes with the DSM-5 as they pertain to clinicians working in an inpatient setting. So the focus for today is obviously some of the basic information about changes in the DSM-5. And we want to make it as relevant to hospital settings as we can, or those of you in tertiary settings as well. So we want to focus particularly on the assessment domains within the DSM and also on interdisciplinary communication. One of the functions of the DSM is that it gives us a common language to talk with each other. And so I think one of the key roles that clinicians have in an inpatient setting is to be able to observe symptoms and to be able to communicate that symptoms across their team to the physicians and to other staff members. And so we want to be able to take advantage of this common language that we have within the DSM-5. Okay, so number one, the DSM is important. The function of the DSM is largely to improve our clinical treatment. And so you can't really have a very good treatment plan if you haven't done a really good assessment. And a key piece of an assessment is arriving at some sense of the diagnosis. So the better our diagnosis, the better our assessment, and subsequently the better our treatment plan. We can tailor the treatment plan not just to the personal characteristics of that individual, but to the way the symptoms are presenting themselves within the individual. One of the things I think that the DSM helps us do is go beyond just the obvious symptoms that a person has. But we can start looking at comorbid symptoms and other issues that may go on with the individual, because the DSM prompts us to kind of look at other pieces to the clinical picture. And sometimes this is really important if we're, for example, having someone that's presenting with kind of low energy, they seem unmotivated, we might jump to the conclusion that they have a major depressive disorder. And that would make sense. But how do we separate that and rule out the possibility that they're actually having beginning stages of schizophrenia? And so the DSM helps us differentiate between different diagnostic presentations that, of course, will have an impact on how we proceed with treatment. Communication, of course, is a key piece of it. It gives us a common language, and we just talked about that a few seconds ago. The other thing that the DSM does is it helps organize the information, and not just information within the DSM itself, but research literature, literature about different treatment protocols for different disorders. And so now it's much easier to look up, if you look up depression, okay, what are the supported ways to treat depression? It helps inform our treatment, it helps educate us, and gives us access to more informative information. Okay, two. Now, I think as most people know, within the DSM, they've dropped the 5-axis way of organizing the diagnosis. So we no longer have this 5-axis system. So instead, when you put down a diagnosis, you will put down just each of the diagnoses, and you can put them down in sequence or in order of their importance. So some of the thinking behind why they did this, in part, one of the main reasons was the physicians themselves felt that other medical areas don't organize diagnoses in this way. And so it kind of put them at odds with how other disciplines within their professions did it. But also we've got things like the separation of Axis 1 and Axis 2. It seemed to imply that somehow an Axis 2 disorder was less relevant than an Axis 1. It kind of had a different status. And that didn't make sense, so they put them all together. Axis 4, the environmental psychosocial disorders, are not listed in a fourth axis, but you can still list them as part of the diagnosis. So in the DSM-4, there was what was called V codes, which were areas of clinical attention, but you wouldn't consider them psychiatric disorder. So something like a marriage problem. It might be part of the clinical picture and might be part of what needed to be focused on in the treatment, but you wouldn't consider it a psychiatric disorder. So those were V codes. The psychosocial and environmental problems have now been moved into that category. Now, I'll get into a second. They're no longer called V codes, so I don't want to say they've moved to the V codes, but they can now be listed and coded. And they've actually given them more detail than what they had before. Axis 5 has now been dropped, so we won't be doing the GAF anymore. Now, there has been some discussion, and the DSM-5 introduces a new assessment of functional ability called the WHODAS, the World Health Organization Disability Assessment Schedule. And so some of you may be interested in taking a look at that to see if it's useful in your setting. So let's just kind of take a look at how it lays out. So on the left there is how you would list the disorders in the DSM-4. And then in the DSM-5, you just list them in whatever order that you think is relevant. Now, I want to point out the numbers here. You'll notice that the numbers are different than what was in the DSM-4. This is an alignment with the International Classification of Diseases, or the ICD-10. And so these codes match with that. And that's trying to bring the two coding systems closer together. You'll notice with schizophrenia, there's actually a lot of information that's added in here as well. I'm not sure how much we'll participate in doing all of this, but there's a lot more room within the diagnosis in the DSM-5 to communicate information. A lot more attention to specifiers and a lot more options that a clinician can put down. We still can put down a personality disorder, and I think, I've got two there. And again, there's what was the Axis 4, but again, it's a little more detailed. It's not just a housing problem, the person is homeless. And then, of course, we can put in our medical conditions as well, though we don't do that on the MRR. Okay, now this is, I got a little close-up here of it? There we go. So this is the WHODAS, the World Health Organization Disability Assessment Schedule. So there's 6 domains that are assessed, and this is largely done with the person present in a verbal conversation. You don't actually test it with the person. And then individuals are scored. And I think there's 30-some questions with this. It's not a requirement of the DSM-5 in the same way as the GAF was, so it's optional. So I think it'll probably be a program-by-program decision to decide whether you do that. It takes more time than the GAF took, and it just focuses on function as opposed to severity of symptoms. So if you're in an acute setting, you may be more interested in the severity of the psychiatric symptoms than the functional side of it. But take a look at it, and we'll see how that kind of pans out in different locations. Okay, 3, there are new categories and new disorders, and so there's been some reorganization here with some additions and some subtractions. What they're doing in the DSM is organizing information, and many professions do that. If you were a chemist, you would work with the periodic table of the elements. If you were a biologist, you would work with different, organization about how we organize animals into different species and the like. If you were a meteorologist, you would have an organization system by which you understood different kinds of clouds. And so this is very common in the scientific world to organize information, and we all do this. We organize our closets, we organize our spice rack, our cutlery, our shoes. And we do this to make it more practical for us. So in the sort of grouping of things and splitting of things within the DSM, they've come up in the DSM-5 with 21 different categories. So this is up from the 16. Now this is largely because they have separated some categories. So in the case of mood disorders, we now have bipolar disorders as one category, and we have depressive and related disorders as another category. So that increases the count. So they've done that a number of times. In the case of disorders, we see we've gone from 172 to 157 disorders. And that's largely because they've combined a number of disorders, and we'll talk about that in a second, particularly with substance use. They've added new disorders, and then they've eliminated a couple. So let's take a little closer look at this. So in terms of the categories, so bipolar and depressive disorders have been separated. Anxiety disorders was divided up a fair bit. So that there's the primary anxiety disorders, things like panic attacks, agoraphobia, social phobia, your specific phobias. They pulled out OCD and related disorders. So obsessive compulsive disorder, body dysmorphic disorder, your trichotillomania and skin picking has been added there. And they've created a third category, and this is quite interesting. They've looked at the disorders that are triggered by stressful events, and particularly PTSD and the adjustment disorders. And so that they've created a separate category for that. I've listed a few other changes down there, but well, we don't have time to kind of go through it all. One of the big differences is they no longer separate child and adult disorders. So in the DSM-4, the first chapter was devoted to disorders that begin in childhood. They've relabeled this neurodevelopmental disorders and focused on those disorders that are of a developmental nature and occur during the development of a person. They felt that the separation of childhood disorders from adult disorders was really a function of how psychiatrists organize their work. There's child psychiatrists, there's adult psychiatrists, but that didn't necessarily fit for disorders themselves. So, for example, as we know, schizophrenia often starts in late teen years, and in a person's youth. Is that a youth disorder or is that an adult disorder? Well, it's kind of irrelevant, actually. So they got rid of that separation. It also includes sort of an acknowledgement that there are disorders that we tend to focus on as disorders in youth, but these also can be disorders in adults. So, for example, attention deficit disorder can quite clearly continue on into adulthood, and so it shouldn't be just seen as a childhood disorder. Similarly, some disorders that we would only have looked at in childhood, we can now look at in adulthood, such as separation anxiety disorder. And so there's some criteria around how that diagnosis would look in an adult. So here's a list of some of the new disorders, and I'm going to just kind of highlight some of them here. Hoarding disorder has been pulled out of OCD, the feeling that it had some unique features to it that made it different than the other forms of OCD. Binge eating disorder. There tended to be an overuse of the NOS category within eating disorders, so they added in this additional disorder to kind of capture some of that. And so binge eating disorder refers to individuals that eat a lot of food in a short period of time, but don't engage in any kind of purging activity as you would with bulimia. So it's capturing another group of people. Mild neurocognitive disorder, we'll talk about it in a minute, which is looking at cognitive disorders potentially in an earlier phase of it, so we can pick it up earlier and start treatment earlier. And also wanted to highlight they've dropped polysubstance use disorder, and they now want us to be a little bit more specific about the substances that an individual is using. Okay, now let me just take a minute and talk about the NOS category. So in DSM-4, we have this grouping of not otherwise specified. That's now been split into other specified or unspecified. So these generally are for individuals, they don't meet the full criteria for a disorder, but it now has the option of giving the reason as to why the person doesn't fit the full disorder. So you would use other specified if you wanted to communicate what the reason was they didn't meet the full disorder. Or you could use unspecified, which is when you don't want to communicate the reason there. And so there's a couple of examples. So either specified depressive disorder, short duration depressive episode, or you could just go with the unspecified disorder. Now, one of the functions of these options are that sometimes you don't have enough information to make a diagnosis. And Mo and I were talking about this earlier this morning, and I understand on an inpatient unit, it's not uncommon for a person to present on the ward. And at the beginning, when you have to do this MR coding, but you may not have completed all the assessment information at the time. And so these categories were set up for that type of situation, say an emergency room, and the physician isn't able to gather all the information, and so they could use an OS or a US category. And so but it does allow you to kind of indicate the general ballpark. So it's kind of in the depressive category, or it's in the psychotic category, but we're not really have enough information to be definitive. And just comment, no change in personality disorders. There was a lot of discussion about making changes there, but the proposed changes just seemed a little too complex. So so things have stayed the same. Okay, schizophrenia spectrum and other psychotic disorders. So I'm sure these are quite common on your inpatient units. Things are pretty much the same there. No additions there, other than a little bit of playing around with sort of the catatonic piece of it. And so you can now have a catatonia associated with a variety of disorders, not just with schizophrenia. Now, what's interesting is kind of how they've organized the categories and the assessment. And I think this is relevant to those of us who are involved in the assessment of individuals with serious psychiatric conditions, and particularly psychotic presentations. So I'm sure you're familiar with each of these terms, but these are seen as the 5 main domains. So your delusions, your hallucinations, your disorganized thinking, which presents itself in the form of speech. So you're looking at how a person speaks as a reflection of how they think. Grossly disorganized or abnormal motor behavior, so kind of silliness or catatonic types of stuff. And then, of course, the negative symptoms of diminished emotion, that flat affect, or avolition, difficulty engaging in a goal-directed task. So these 5 domains are identified, and so what the DSM-5 asks us to do is assess these 5 domains. Then based on how that turns out, looking at, then you can kind of figure out which category or which disorder best fits the individual. So I've kind of put it on a chart here. Now, one of the things that's interesting, I should make the comment, schizotypal personality disorder is now co-located both within the chapter on personality disorders, but also it's co-located with the schizophrenia spectrum disorders. And the reason for this is, as a personality disorder, there seems to be a close connection between it and schizophrenia, that individuals with this type of personality may be more likely to move on to develop a full-blown schizophrenia. So they've co-located it there. But again, it has none of the domains. It just got that odd behavior and that difficulty with interpersonal relationships. So delusional disorder, so just has the one domain of a delusion, but it also now is no longer limited to just non-bizarre delusions, so it can include bizarre delusions. Pre-psychotic disorder, pretty much the same. Schizophrenia and the schizophrenia form disorder, of course, schizophrenia form disorder is individuals who haven't met the full 6-month criteria for schizophrenia. They've raised the symptom threshold to include 2 of the active phase symptoms. So the active phase symptoms are, going back here, your delusions, hallucinations, and disorganized thinking. So you have to have 2 of those now to meet the criteria for schizophrenia and schizophreniform. And then you have to have the negative symptoms or some of the other symptoms. And in the case of schizophreniform, it's less than 6 months. In the case of schizophrenia, is over 6 months. The other thing they've done with schizophrenia is they've dropped the subtypes. So paranoid, disorganized, undifferentiated, etc. have been dropped. So catatonia can still be a specifier. The reason they did that is because they didn't seem to be sort of functionally that useful. There's many people that believe with schizophrenia that it actually, as a category, represents multiple different types of disorders. And they kind of thought the separation of paranoid, disorganized, etc., was kind of the direction that they needed to go. But it turned out from a research perspective that it's not that useful. And you see a person over the course of their life kind of moving from one category to another category. So it didn't make clinical sense to keep it in. Schizoaffective disorder, the big change here, as you know, you've probably seen lots of individuals that get diagnosed with schizophrenia, and then another time they're diagnosed bipolar, and then they're diagnosed schizoaffective, and there's kind of this kind of moving target. And they wanted to look at schizoaffective disorder in a much longer-term way, that if a person had a diagnosis of schizoaffective, it kind of would stick a little bit longer. And so one of the ways they approached that was to look at how long the mood disturbance piece of it lasted. And so now to give a diagnosis of schizoaffective disorder, the mood disturbance needs to be there the majority of the time. Now, there needs to be a period of time when there is no mood disturbance, but there are the active symptoms that you'd have in schizophrenia. But then there's the majority of time, there's either the depression or the mania. And that's a change. It's been increased. Now, in the diagnosis, there's room to be fairly detailed about the severity of the psychotic symptoms. And so we have 8 domains. We've got the 5 dominant domains here. I'm not circling that very well. And then they've added impaired cognition, depression, and mania to capture the full picture that you might see in a schizoaffective presentation. And then you can rate this from 0 to 4 on this scale. I'm not sure how much this is going to be used. Technically, it's to be included in the diagnosis, but it takes a fair bit of extra work, and so I'm not sure how much people are actually going to do it. What I do like about it is it gives you kind of an assessment framework to looking at these symptoms and a way of looking at how severe are the symptoms. So you want to be able to say more than just they're having hallucinations, but you want to, what kind of impact is that hallucination having on them? How pressured are they feeling with it? Are they feeling that they have to respond to the hallucination in some way, or do they just kind of live with it? And so it gives sort of a way of looking at severity, which I think is important in assessment, but it also gives us some tools about language. So when you're talking within your team, you can say, how severe the delusion is, and it gives you some words to use with that. Okay, bipolar and related disorders. So again, not a lot of big changes in the categories. Bipolar 1, bipolar 2, cyclothymic disorder. I think we're all familiar with that. The issue in the DSM-4, and there was a lot of discussion about this, is there was a feeling that bipolar disorder was being overdiagnosed. And the justification for that was the increased rates of people being diagnosed. And this was particularly of concern in children, that the rates of that diagnosis in children had skyrocketed since the DSM-4. And so there was some concern about that and concern with what they called false positives. So they tackled this in a couple of different ways. One is they made it the criteria for mania a little bit trickier, or no, I don't know, not trickier, but wanted more to it than just elevated mood. But they also wanted increased in activity or energy. So often those go together, and so that's not a big deal. but there needed to be some other sort of objective, observable information there. Also, the mood disturbance part now needs to be most of the day. That should read nearly every day. Whereas in the DSM-4, it was just a substantial portion of the day. So bipolar needs to be more than just kind of mild fluctuations in mood that people get kind of hyper for, a couple hours. But it needs to be predominantly there most of the day, nearly every day. The other change that they made was this creating a diagnosis, disruptive mood dysregulation. And so this is for children and youth. What they found with the diagnosis of bipolar in children is that often those individuals, when they became adults, didn't go on to continue to have a bipolar disorder, but they were more likely to be in the depressive or anxious category. And so within children, they're able to identify a group of kids who have, emotional outbursts, kind of, excessive temper tantrums that are beyond what you would expect for their developmental age level. And so this can be captured in this new category, disruptive mood dysregulation. And then as they become adults, it can be looked at through a new lens. Treatment-induced mania and hypomania. So I'm sure you guys have all seen clients where they're being treated for depression with an antidepressant, and then they go into a hypomanic or a manic episode. The DSM-5 has clarified this as that this should be considered a true bipolar if the response is beyond what is expected of the treatment. Previously in the DSM-4, it would actually be considered a medication-induced mania, but now they've concluded that that's a true bipolar presentation. Changes with depressive disorders. So a little bit, so this disruptive mood regulation kind of falls actually within the depressive disorder. Again, major depressive disorder, same as before. Persistent depressive disorder is a reworking of the diagnosis of dysthymia. And so what they've done there is they've said the duration of depression is more significant than the number of symptoms. So dysthymia in the DSM-4 was considered a low-grade depression. You didn't quite have all of the symptoms of a major depression. What they're saying in the DSM-5 is that really doesn't matter that much. If it's been going on for a long time, we should take it more seriously. And what they've lumped in with it is individuals with chronic depression. So if you have a depressive disorder that goes on for at least 2 years without more than a 1-month break, then that'll be now considered a persistent depressive disorder. And that's lumped in with what was previously dysthymia. This kind of gets rid of that kind of what was called kind of a double depression, where people would be in a dysthymia and then drop into a major depression. We're not seeing that as distinctly different now. We're now seeing that within the same category. Premenstrual dysphoric disorder has been added in. That's been on the books for a long time, and in the DSM-5 it's become official. Now here we get an example of how we're using the specifiers to measure severity. So on the left are the 9 symptoms of depression, and we can rate it mild, moderate, or severe. And we do that by counting the number of symptoms. So if it's just kind of 5 symptoms, it's mild. As the number goes up, it becomes severe when accompanied by unmanageable distress. Now, another feature that they've added in is a specifier for anxiety. So as you, in the DSM-4, anxiety was separate from depression. But as you know, you very often see individuals who are depressed, but who also have a lot of anxiety. And the research has indicated that this is predictive of poorer outcome and higher suicidal risk. So when you got that combination, the person needs to be seen as having a more serious of a condition. And so we can rate this anxiety from mild, moderate, severe, and severe. Now this anxiety, this anxious distress specifier is also applicable to the bipolar disorder. And I was just listening to a talk this morning about the relationship between anxiety disorders and bipolar disorders. And it's quite common for them to be comorbid with each other. Now, if a person has a full-blown anxiety disorder, that diagnosis would also be made. But this anxious distress specifier is a bit of a flag to potential difficulty in the treatment and a risk indicator. Okay, so moving on, 7. No more substance abuse, substance dependence differentiation. So as you recall, in the DSM-4, there were separation between a diagnosis of substance abuse and substance dependence being the more severe. In the DSM-5, they felt this was an artificial separation. It's really one issue, which is an addiction issue, and one is people are on a continuum of less severe to more severe, but it didn't justify separating the two apart. So what I've done there is I've listed the 11 criteria. You'll notice I've crossed out legal problems. So in the DSM-4, that was one of the criteria for making that diagnosis or clinical impression. How different parts of the world respond to a legal problem or the legal side of addictive behavior, it really varies across the world. And so in one country, you might have police out all the time catching drunk drivers, and other places you might not. And so it didn't really make sense that how often you got caught was really indicative of whether you had a disorder or not. In its place, they've added the criteria of craving. And this is probably significant from a research perspective. Craving is something that we can identify in an individual. Individuals can talk about it, but it's also something that can be identified biologically. And you can put people in a PET scanner, and you can observe how craving works in the brain. Now, from an assessment perspective, we have 4 basic domains for substance use. So impaired control, social impairment, risk of use, and pharmacological aspects of tolerance and withdrawal. Now, just as a side note, tolerance and withdrawal are only considered with substances that haven't been prescribed. So tolerance and withdrawal are characteristics of medications that are used to treat disorders, particularly pain. And so it's not necessarily a sign that a person is an addict simply because they're on a medication for their treatment that they require. We even see this with antidepressant medications. The body builds a tolerance. If you pull the antidepressant medication off too quickly, the person can have withdrawal effects. This is not seen as a function of addiction, but just the nature of how the body works in interaction with a medication. Okay, I'm going to just take a look at the chat line. We have a note here. This may be relevant to repeat, but I thought Dr. McIntyre's point, if a person is hospitalized, they warrant mania diagnosis over hypermania. Yes, absolutely. So one of the diagnostic one of the ways of distinguishing mania and hypomania is, does the person need to be hospitalized? And if they need to be hospitalized, they've already moved from the category of hypomania to mania. Okay, neurocognitive disorder. So I think some of you are working in settings where you're working with individuals with dementia and Alzheimer's disease and the like. So in the DSM-5, they've dropped the word dementia. And the rationale for this is 2 things. One is they felt that there was some stigma to the word dementia, but also that the word dementia was poorly understood. It tended to be associated with just Alzheimer's disease, and it also tended to be associated with memory loss. And dementia doesn't require a memory loss. It's often there, but it doesn't have to be. And so they're using the word neurocognitive disorders now. Within this category, there's delirium, major neurocognitive disorders, and mild neurocognitive disorders. Mild neurocognitive disorders is a new category to catch that kind of the early phases of of cognitive decline. I'll go into a little more detail with that, but with the domains, there's 6 domains for assessment in terms of cognitive functioning. So complex attention, executive functioning, learning and memory, language, perceptual motor, and now social cognition. And so you're looking for impairment, cognitive impairment along these domains. And so now the DSM provides you with a chart for that. And again, it gives you some very good specific examples. So I've just cut out a piece of it here for the domain of complex attention. So it describes the symptoms that you would observe and gives you examples of how you would assess for that. Here's a slide that from an APA presentation. So if you think of mild neurocognitive disorder as kind of in between major neurocognitive disorder and what would be normal age-related cognitive decline. So, as we age, our brain isn't quite as sharp as it was. But that doesn't mean that you have a cognitive disorder. That's just kind of a normal aging process. We start looking at mild neurocognitive disorder when you've got the cognitive decline. And we have in that list of 6 domains, there's one area that's particularly impaired. But the impairment isn't such that it interferes with the person's independence. They can still take care of themselves, they can still manage, and they don't need additional care. We start moving into major neurocognitive disorder when more than one domain is affected and the person loses their independence. They require the attention and care of another person in order to be able to function in life. Delirium, not a lot of big changes, just some changes in the wording. Disturbance of consciousness. I was kind of glad to see this. I always found that a little bit confusing, kind of what that meant. So they've dropped that and gone with disturbance of attention and disturbance in awareness. So mostly wording changes. And of course, there's you have a neurocognitive disorder due to something. So in DSM-4, it was dementia due to Alzheimer's disease. Now it's neurocognitive disorder due to Alzheimer's disease. Now, I was asked to put in a little bit on cross-cultural formulations because I think this is a common issue on a unit. As our world becomes more and more multicultural, it's important that we be able to see beyond the boundaries of our own culture. So they've done a couple of things. They've tried to be more sensitive to the fact that symptoms can present themselves differently across culture. So, for example, panic attacks, one culture may focus more on crying and headaches, whereas in our culture we'd focus more on difficulty with breathing. And they tried to make some of these adaptations within the DSM-5. So, for example, social anxiety now includes the concept of offending others. So typically, we look at social anxiety as where a person's anxiety goes up because they're fearful of the judgment of others. They feel embarrassed in front of other people. They're fearful that they're going to do something that's going to make themselves look silly and foolish. But now they've added this idea of offending others to reflect a more Japanese concept of harm to others. And they've tried to pull in sort of the cultural concepts of distress, looking at different syndromes, idioms, and explanations. And so if you go to the full text version of the DSM-5, with each disorder within the explanatory text, it will make some comments about the cultural concepts of distress related to that disorder. So you can specifically look that up. In the index, they've also put in a cultural formulation interview. So there's a patient version with 16 questions and an informant version with 17 questions. So you might want to take a look at that if you are running into individuals from other cultural groups than the one that you're familiar with. And these interviews are divided into 6 categories. So how does the culture define the problem? How does the culture explain the problem? What kind of stresses and supports work for that individual within their individual and cultural context? What role does cultural identity have? And cultural factors that affect coping and help-seeking, past and present. What I did is I highlighted some questions. There's 16 there, but I thought I'd highlight just a few of them. So how would you describe your problem to your family, friends, or others in your community? So that's looking at how does the community look at this problem. What do you think is the cause of your problem? So again, that gets at to a cultural explanation. What are the most important aspects of your background? What do they value that they bring to your setting? What kind of help do you think would be most useful to you? Right? So what kinds of culturally based solutions would they be looking at? And then I like this last question. Sometimes staff and patients misunderstand each other because they come from different backgrounds. Have you been concerned about this? And is there anything that we can do to provide you with the care you need? So again, eliciting their perspective and their ideas of what a solution looks like. Okay, MRR. So this, I think, is an area where people are curious about how life will change. So this is going to be coming in pretty quick here. So currently, the MRR, it has a separate screen for the diagnostic categories, and it lists the 5 axes minus axis 3. In the new screen, there will be room up to 5 diagnoses or diagnostic impressions, and you're asked to rank them as what's most important to least important, so primary, secondary, etc. There'll be a text box that you can expand on the diagnosis and code. So sometimes the diagnosis we have a DSM-5 dictionary now that comes from Meditech, who got it from the American Psychiatric Association. And some of the diagnoses include the specifiers and some of them don't, just the way the coding works. So you will have text room if you want to add some of the specifiers, differential diagnosis, or any kind of personal note. Now, we don't have a screenshot of it all yet, but here's a screenshot of the dictionary. If you type in depress, right, you don't even have to do the whole word, and then it'll give you a list of all the disorders with the letters depress in it. And so this should make it fairly easy to find things if you're not familiar with the exact codes or the exact name of the disorder. Now, one of the kickers with this new dictionary is there's no longer no diagnosis or diagnosis deferred. So I know clinicians have used these a fair bit, and particularly the diagnosis deferred. Mo was telling me this morning that that's often used when a person is first admitted to hospital because you haven't finished the assessment information. Presumably by the time the person is discharged, you have a discharge diagnosis. But often at the beginning, that might not be available. So this presents a bit of a challenge, and we have some thoughts about that. But we are making the assumption that if a person has reached the point of our system that there's a level 3 assessment, then undoubtedly there is a mental health or substance use issue present. So we're not so worried about the category no diagnosis. So some of the things that you might want to look at is if we go back to the unspecified category and the otherwise specified, I think these are reasonable ones to use when you're not sure. So hopefully you can kind of figure out that ballpark. Is this kind of a depression kind of thing? Is this a psychotic kind of thing? And then you can use the unspecified or the other specified coding for that. Now, if there was a case where there was no diagnosis, then you probably have some kind of Axis 4 type of presentation, where there's some kind of social problem, and of course you can code for that as well. Now, there's a question here, where can clinicians find the coding dictionary? So it's just a simple matter of the lookup. So when you're in the box that you would fill in the diagnosis, you just do a search. Now, if you want just a list of all the codes and all the disorders, in the beginning of the DSM-5, there is a listing of them all there, and they're organized. One is organized by the number, and the others are organized by the traditional categories. Okay. Now 11. So I lied to you. I said there was going to be 10 top 10. I just couldn't fit in 10. I had to do 11. So I hope you're not terribly disappointed with that. So I think when we've been kind of thinking about this and planning this ever since the DSM-5 came out, and we kind of had two objectives here. First, the objective, of course, was to prepare for the changes in the DSM-5. Things weren't going to be exactly the same, and clinicians needed to be apprised of these changes. But the other part of it was we kind of thought, well, maybe this is a time to encourage people to take a closer look at the DSM, enhance their skills with the use of the DSM, particularly as it related to assessment. And so we kind of want to push this a bit for people to kind of take this opportunity to learn more about the DSM and to improve your skill level in its use. So there's kind of two sides to this. One is sort of knowledge of the disorders. The DSM-5 and each one that's come out, they kind of represent a snapshot of our knowledge of the disorders at that point in time. And a lot of it is written down within the DSM book itself or in relevant literature. And so I hope you'll take the time to kind of read the chapters on the disorders that are relevant to the clients you're seeing there. Perhaps you have an interesting case of an individual with depression, and you want to kind of bone up on your knowledge about depression. Pull out the DSM-5 and kind of read the explanatory text that goes with that. So I kind of want to encourage you to do that. The other is kind of the assessment side of it. I think learning those different domains that go along with each of the categories, and then also the process of doing a differential diagnosis. So what a differential diagnosis is, as many of you know, is when you ask the question, what else could it be? So you have someone and they come in and they've got low mood and they seem lethargic, and you want to say, okay, this is a depression, but then you want to take a minute and ask yourself, what else could it be, right? Could it be signs of an early cognitive decline? Could it be kind of a dementia, neurocognitive type of thing? In a young person, could it be prodromal symptoms of a psychotic disorder? So by going through a process of asking what else could it be and coming up with differential or alternative diagnoses, it adds layers of depth to your assessment and thinking process. And so those are good skills to develop because they reduce the probability of error. Now, one of the things we've put together is a resource page. And I'm going to just kind of switch things around here a bit and pull this up. I'm going to go to the Inside Net. So what we've done is we've been working on a page on the Inside Net that is a collaboration between tertiary care, acute care, and community care. So if we'll go under clinical care resources and mental health and substance use, we come up to this page. And so there's a whole bunch of resources here, patient and family education, kind of documents and forms. And under education of staff, we have training and staff education. Now, over on the right, you'll see a DSM-5 resource page. You can just click there, or you can go in through training and staff education. And we're just starting to build sort of some resource information here. If you go under DSM-5, you see at the bottom the DSM series poster, or again, this DSM resource page. We click on that, you get this page. And so in it, we've tried to pull together all the different resources that we think would be useful to you. Now, one of the things, here at the top, we've got electronic library resources. So the library has purchased a number of resources, including an electronic version of the DSM-5. So we just kind of open that up. You'll see that there, and you can go, diagnostic criteria and codes, and you can look up, say, schizophrenia spectrum and other psychotic disorders, and then you get into that. So brief psychotic disorder, and you get the diagnostic criteria. So you have access to that, even if you don't have the paper copy on you. There's also a handbook of differential diagnoses, which gives you kind of decision trees, and then clinical cases to look at examples. We've also pulled together, this is a 3-hour video if you want a really comprehensive view of the changes in the DSM-5 done by Dr. First. This was recorded in a presentation he did to Coastal, to Fraser Health and Vancouver Health. We've also included some of the handouts that are available through the APA. So if we decide to look up gender dysphoria, right? So if you want to get some basic information on a particular disorder, you can do that. There's also one sort of on online assessments, which has some very cool stuff. We're also including recordings of our expert speakers. So Dr. Smith's talk on eating disorder, Dr. Weehan's talk on schizophrenia. I still have to get up Dr. Ward's talk on neurocognitive disorder and Dr. McIntyre's talk on bipolar and depressive disorders. I've included this. I sent out on the mailing list the PowerPoint slides and this page. And if you get an older version and you want to see what the newer version, if you go to the bottom here, just click on I need to find, and it will immediately bring you up to the latest version that we have. So hopefully that'll be useful to you. I'd encourage you to do some talking with your team if there's needs you have to feel more comfortable with using the DSM. I know filling in that MRR and putting in a clinical impression when a physician hasn't come up with one yet can be a little bit intimidating. And so if there's anything we can do as a knowledge coordinating team, as educators, to help you with that, just let us know. And perhaps there's things that you may want to do at a local level to kind of bone up on some of your knowledge and skills with that. We've got a couple of minutes. Are there any questions here? I see there's one. Are there teaching modules on iLearn for the DSM-5? If so, might there be associated tests, thinking similarly to the violence intervention training modules? So we do have 4 iLearns on the DSM, and we've done them more generically in the sense that it's basic information about the DSM. And so there's 4 different ones. One is on kind of roles and expectations. One is kind of on organization and structure. One is on controversies. I'm sure as all you have seen, there's been various things in the media. There's certain groups that are quite strongly opposed to the DSM or psychiatry in general. And so we talk a little bit about some of those controversies, because I think these are things we need to kind of have our own head around so we feel comfortable using it, and also so we know how to respond to our patients and clients and families when they have questions. And then the 4th one is on how to do a differential diagnosis. So just go on the iLearn system and you can sign in there and take one of those. We haven't gone so far as to do tests, and not a bad idea, but we haven't kind of crossed that line with our training yet. Thank you all, and any sort of feedback on what you need or how we can support you is always appreciated. So we'll sign off there, and everybody have a good day.